Welcome to session 4, entitled Managing Virological Failure. My name is Brendan Larder, and my co-chair is Dr. Anna Wen Singh. We will have 2 presentations during this session. Please can I remind you to put your questions in the chat, as we'll have a live discussion at the end of the second presentation. The first speaker is Dr. Leon Levine. Dr. Levine is a paediatrician who has been treating HIV-infected infants, children and adolescents for the past 25 years. His current interests include infants, children and adolescents with HIV infection, new paediatric ART formulations, treatment failure and drug resistance, and HIV disclosure to adolescents. Dr. Levine's presentation is entitled HIV Drug Resistance, Bench to Bedside.
Thank you to the organizers for asking me to give this talk. These are my conflicts of interest. I'd just like to show where my bias lies, because I've been asked to talk from bench to bedside, and my bias lies firmly towards the bedside. I'm a clinician, and in fact, I'm a pediatrician as well. So just so you're aware of where I'm coming from, that I'm not too familiar with the lab processes, but I have had some help in that regard. So what should be the natural progression in managing our patients with treatment failure? Obviously, you should have pre-treatment resistance testing, and if a patient fails the regimen, we have resistance testing, design a new regimen. That's the way it's done in the Western world. So what are the barriers to that natural progression? Why are we not doing this in sub-Saharan Africa? So firstly, there are logistic issues, costs, adherence is a problem, the barrier, and the span in the works. I'm going to address each of these 4 things. Let's look at logistics. Now, speaking to my colleagues who work in the lab, the biggest problem seems to be dry ice. Dry ice is very difficult to get a hold of in Africa, and it's very expensive. And if you're going to centrifuge a sample and store it minus 70 degrees, it needs to be transported to the lab on dry ice. If you haven't got dry ice, you can get it to the lab in 2 to 3 days if it's transported at 4 degrees Celsius, but that doesn't always happen. And dry blood spots allow you to have a longer time to get to the lab, but the trade-off is reduced sensitivity in your viral load of at least 5 to 10,000 copies per ml, and also needs a desiccant pack, which adds to the cost. Right, what about the costs? So to overcome the barriers, we can look at cheaper tests, less tests, more focused tests, and using surveillance to pick up trends and guide us in our treatment decisions. So cheaper tests, I'm very thankful to Professor Bob Schaefer for helping with the slide. So I'm not an expert on this, I'm not going to go into detail. The bottom line is there are cheaper tests which are available, okay, but very much dependent on labor. And you need to batch your samples, you need big numbers of samples, 100 samples at a time would reduce your costs, but of course it also adds to the turnaround time. And also costs don't include cost of sequences, which can be as much as 5 million rand for a machine. So what about doing less tests? In sub-Saharan Africa, obviously we can't afford to do baseline resistance testing, but we rely on surveillance, and that has been done pretty well. Patients failing a non-nucleoside regimen, well, we don't need resistance testing. We've got the NADIA and ARTIST study showing that if you change them from TEE to dolutegravir regimen, you don't need resistance testing, and Ernest second-line select showing the same with a PR regimen. Same thing with failed dolutegravir regimens. Ernest second-line and select telling us we can use a PR regimen second-line. We can have fully resistant NRTIs. We don't need resistance testing for that. So the one place where we still would need resistance testing would be after a failed PR regimen. And we're not certain if dolutegravir is going to change that. If you look at our South African adult third-line committee algorithm, you can see that patients need to have resistance to either lopinavir or atazanavir. We'll all get dolutegravir ritonavir plus 2 nukes. Okay, and if there's intermediate resistance or worse to tenofovir or AZT or low level to darunavir, then add in dolutegravir. And if there's both resistance to the 2 nucleosides plus resistance to darunavir, they would add nitravir. And this has been validated, and this was in the days before dolutegravir, so they were using raltegravir instead of dolutegravir, and 80% of the patients had a viral load below 1,000 copies per mol in those who had a viral load done 6 months after switching to third line. But to do this, you need to know that they have PI resistance. So what about doing more focused tests? If we just need to know they've got PI resistance, okay, or you could argue with integrase as well, why do we need to look for reverse transcriptase resistance? Third line committee in South Africa requires PI resistance. So why don't you just do the PI test? Or in pediatrics, where you do integrase resistance as well, the integrase test as well. And then, so that will allow you to screen out those patients who need third line regimens. And then you can add in reverse transcriptase if you want. But some countries have basically got a generic third line regimen, TLD plus darunavir. So then it doesn't really matter. You don't really need the reverse transcriptase. You can say this is a third line patient, they get the third line regimen. You're saving the costs of doing reverse transcriptase, which is quite a lot. In fact, one of the private labs will do a PI or integrase resistance only for $80, which is quite considerably cheaper than what we are getting at the moment. And the last way to reduce costs is to do surveillance to pick up resistance trends. So obviously, WHO, we're doing pre-treatment HIV drug resistance, very, very important. And that's on what we base the decisions to change our first-line regimens. And in fact, we've just done this recently, changed to dolutegravir. But what about acquired HIV drug resistance? So there are specific situations, and we can use surveillance to help us in those situations. For example, this was a situation, remember I'm a pediatrician, where we put together our 2019 new guidelines. This was obviously pre-NADIA and ARTIST. Patients with failing TE regimen would get AZD3C and dolutegravir. But if the patient is a non-adherent adolescent, this is not a great regimen because it's twice daily, not particularly well tolerated. All right. But you needed an active NRTI because we had the Dawning study, but it was pre-NADI. Okay, but what about patients failing a Backup 3-TC efavirenz? So according to the guidelines, they should also get AZT3C dolutegravir because then you're going to have an active NRTI and AZT. But these are adolescents. Are they going to take this twice daily regimen? No. So what about TLD in those patients? It would seem like it would be ideal. Okay. But a Backup can give rise to K65R. So then you've got resistance to tenofovir. You're not going to have an active NRTI. But how common is K65 after Backup in South Africa? And this is where we went to the lab and we said, how common is K65R? And we looked at 2 pediatric cohorts, and one cohort, K65R was 6% in patients failing a non-nucleoside regimen, and 1% patients failing a PR regimen, and the other one, K65R, was 1.8%. In fact, resistance to a Backup GSS below 2 was 7.8% in the Backup exposed, had resistance to tenofovir. So basically, putting them all together, we've really got less than 10% of patients failing a Backup 3-TC regimen are going to have resistance to tenofovir. So now we have to make this decision. Do we punish the 90% of patients who don't have resistance to tenofovir, who could get by with TLD or once daily regimen, and say, no, we're going to give you a twice daily regimen because 10% of you have got resistance to tenofovir. And we don't even know what that means. Okay, but 10% have resistance to tenofovir. So but we're talking about non-adherent adolescents, so we took the public health approach to say, you know what, okay, we want to have the best good for the majority of our patients. So in our guidelines, all adolescents in South Africa failing a Backup 3-TC efavirenz regimen will now receive TLD, providing, of course, they meet the criteria of being over 10 years and over 35 kilos. And yes, there will be 10% of patients who will have resistance to tenofovir, and we didn't even know what that meant at that point in time. And now we know in hindsight that with NADIA, that it probably wouldn't have made a major difference, and those 10% probably will be okay because of the NADIA study. But that's how I'm showing we can use the lab and doing resistance testing on a cohort of patients to determine the trends that allow us to plan our guidelines. Now, what about adherence? I'm sure you're surprised, say, why am I putting adherence as a barrier to resistance testing? The problem is, and I'm sure you've seen it, okay, if the patients are not adherent, we will not get an accurate resistance test. The wild type kind of susceptible to everything, and it doesn't help us. And the problem is that no patient wants to be caught in a lie. So if you say, are you adhering? Are you taking your treatment? Yes, I'm taking treatment. Then you say, we're going to do this resistance test, but you have to be taking your treatment for it to be accurate. Are you taking your treatment? They're not going to say, oh, doctor, I was lying before. No, of course you're not going to be caught in a lie. So they're going to say, yes, I'm adhering. They'll do it, and it'll be susceptible to everything. It's not going to help us. Okay, so how do we get away? So what I do is I just say to the patients, look, I know things might have happened before, but we want to get an accurate test. So just for 1 month from now on, take it every day, and then we do resistance testing. And that way we don't have to force them to lie, because we're not asking what happened before. We just say for 1 month, please take it. And I must say, since I've been doing that, it's a long time since I've got a susceptible to all, showing the patient not adhering. And in fact, there's a study published recently showing that you can do ARV drug levels, which will also, assess if they're adherent, and with a good correlation with adherence and resistance. And then obviously you would only do resistance testing on the ones who've got detectable drug levels. So in other words, you're screening out those patients who are adherent to do resistance testing on them. If you don't have adequate drug levels, then obviously you would tackle adherence again. So that's certainly what we can do. Remember that the cost of drug level testing is 1/10 the cost of resistance testing, but there are also logistic issues as well. But you could, for example, if you're going to send the resistance testing on dry ice, you could send a specimen for drug levels on dry ice too. They could do the drug levels first and then only process the resistance testing if the drug levels are adequate. Right, so what about the spanner in the works? So what am I talking about? It's not necessarily a bad spanner. Dolutegravir. Why? Because dolutegravir is now being used first line, second line, third line, and obviously Nadia and Artist have spearheaded this. The fact that we're not so worried about neural tube defects as well has pushed this to the fore, and literally we are seeing patients on first line, second line, third line dolutegravir, and we are starting to see less resistance. Countries that are using dolutegravir are seeing 90% of the patients suppressed. In Botswana, I've had a discussion with Dr. Avalos, and definitely they are seeing less resistance. Whether this is short term, probably, because you're going to start seeing dolutegravir resistance in a few years' time, and then of course, we'll have to go back. But in the meantime, there's going to be less resistance testing done because dolutegravir is going to solve the problem. So we might have to wait for this pendulum to swing back before we need to continue this discussion, because maybe we don't need so much resistance testing, and we're not going to get the bulk kind of testing that we need to drop the prices. So we might need to wait for dolutegravir resistance to start coming back before we start this discussion again. And what about dolutegravir resistance? As you know, very unusual first-line failures, things like drug interactions, rifampicin, positive cations for sure. But we need surveillance, we need to monitor it, because we need to know what's going on, especially with Nadia, Artist, and DEPT. Yes, they're showing great results so far, really fantastic and gratifying. But 4 patients in the Nadia study had dolutegravir resistance. And the interesting thing is 3 were in the AZT arm, which is with an active NRTI, and only 1 with a tenofovir arm, where there may not have been an active NRTI. So it's not like there's going to be no resistance. We will have resistance. I recently came across a patient, high-level dolutegravir resistance, less than 2 years after switching to TLD from a suppressed protease inhibitor regimen. They were virally suppressed, and now I've got high-level dolutegravir resistance. Very, very worrying. And as it says, dolutegravir being used first line, second line, and third line quite willy-nilly. So watch the space. We are going to see dolutegravir resistance, and then yes, we will need to revisit this discussion, because we are going to need to be doing more resistance testing. So to summarize, I think the important thing is that, as you've seen, clinicians and virologists need to be talking to each other. Okay, it makes a very big difference. I find it phenomenal that I've got these people that I can talk to, and it helps me a lot. Resistance testing needs to be made more affordable and available. We need to be more focused about when we do resistance testing. Surveillance is vital, but we need to target our surveillance as well to answer our clinical questions. And perhaps there's going to be a lull now because of the rollout of dolutegravir regimens, but beware dolutegravir resistance. Just like to acknowledge the people who helped me putting this talk together. Thank you very much for your attention.
Many thanks for your presentation, Dr. Levine. Our next speaker is Chigioke Omiyaki, who is a senior research scientist at Ndlovu Research Department, a research consortium in rural Limpopo, South Africa. Its aim is to directly translate acquired research knowledge into improved public health policies and health and wellness of rural communities in Limpopo. The presentation is entitled Managing Virological Failure in the Absence of Resistance Testing in Resource-Limited Settings. Thank you.
Hi, everyone. I'm very excited today to share with you some work on managing virological failure within the African setting. So we're all aware that sub-Saharan Africa accounts for a huge share of the global HIV epidemic, with more than 2/3 of the HIV population in sub-Saharan Africa. And all 8 countries with more than 10% HIV prevalence are in Southern Africa, shown here in dark blue. And South Africa in particular has the highest number of people living with HIV globally, which is almost 8 million. And we're also familiar with the UN AIDS targets, the 1990 targets by 2020 and the 95-95-95 by 2030 of 95% of people with HIV knowing their status, 95 of those being on treatment, and 95 of those on treatment being virally suppressed. And also the number of new HIV infections that are targeted, and of course, zero discrimination globally. Now, the global progress in reaching the 1990 targets have been pretty impressive. In 2020, 84 of people who have HIV knew their status, and 3% of them are receiving treatment, and 66% of those are virally suppressed. However, you can see that as you go down the treatment cascade, the rate of success is lower, with only 66% of people being virally suppressed. Nonetheless, there are some countries that have reached the 1990 target, and there's some good news in that 5 out of 8 countries that reached the 1990 targets are actually in sub-Saharan Africa, shown here. And 6 of the 11 countries that have reached at least 73% viral load suppression are also in sub-Saharan Africa, shown here. South Africa itself has a very impressive HIV program, but low-level viremia persists. And what I mean by low-level viremia is viral copy, viral load of 51 to 999 copies per mil. So that is still a big problem. So shown here is a study conducted by one of our collaborators, Lucas Ermans, who looked at a cohort of almost 70,000 patients from 57 South African treatment facilities on first-line ART, specifically looking at viral load. And what you can see here is that up to 90% of the patients have viral load less than 1,000 copies per mil, but you still have a significant portion, more than 25%, that have low-level viremia. And low-level viremia has also been shown by my colleague to be associated with therapy failure. So inadequate suppression and virological failure are major challenges in reaching the targets that have been set by the HIV community. Now, shown here is the current South Africa treatment program, where once the patient has initiated ART, they perform viral load monitoring 6 and 12 months, and then annually after that. If the viral load is less than 1,000, then everything is okay. But if it is above 1,000 copies per mil, then they initiate intensified adherence counseling, and then a repeat viral load count 3 to 6 months after rebound. And then based on the viral load copy numbers, will determine what the next steps are. If it is above 1,000, the switch to a new regimen. And if it is below 1,000, then they have achieved suppression again. So you can see here that the factors underlying virological failure and not addressed. And this guideline, this strategy needs improvement. There is no resistance testing prior to switching, which can lead to unnecessary switching in patients. Therefore, there is an urgent need to improve this current strategy and more particularly address the underlying factors of virological failure. So to address this, we developed this strategy called ITRIMA, which stands for Intensified Treatment Monitoring Strategy, to prevent accumulation and spread of HIV drug resistance in resource-limited settings. And the aim of this strategy is to improve the effectiveness of HIV treatment by directly addressing the factors that underlie the unsuppressed viral load. And this is a program that is a collaboration of universities in South Africa and the Netherlands and Ndlovu Care Group, where Ndlovu Research Center is. And a key observation that drives this strategy is that adherence really is the key to achieving and maintaining suppression. So ITRIMA aims to improve the current South Africa treatment strategy by targeting this virological failure step here directly. And we ask the question, is virological failure due to adherence or resistance? And to answer that, we perform a simple qualitative drug level test. And my collaborator has also shown that drug level is an excellent predictor of adherence. So if the drug is present, it indicates adherence in most cases. So using this algorithm, we perform a simple qualitative drug test. If no drug is detected in the patient, then this indicates that there is an adherence problem. And then we perform an intense drug level informed adherence counseling and continued drug level monitoring to see if adherence can be improved. And if drug level is detected after the qualitative drug level test, then it indicates that there might be a resistance problem, in which case we perform resistance testing and switch therapy if we do detect HIV drug resistance. So this strategy is particularly attractive because the drug level testing informs the appropriate reflex action that is performed. And this is based on the underlying reason for the insufficient absorption of virological failure. So if drugs are not taken, then the reasons for non-adherence are directly addressed, whether it is toxicity or socioeconomic barriers like stigma or non-belief in ART or inability to access the clinic. These are all addressed. If HIV is resistant, then the current regimen is replaced by drugs that are active against the virus. And this is very cost effective. It reserves expensive drug resistance testing only for those that are most at risk, and only people living with HIV that have resistant HIV are switched to a new regimen. So it does not unnecessarily switch those who do not need a new regimen. So we have performed some validation of this strategy. For the interest of time, I will not go into the details, but we can perform plasma drug level testing using a chemistry analyzer, and we can detect lopinavir, efavirenz, and dolutegravir. The dolutegravir validation is currently in progress. We can also leverage a simple lateral flow device to perform drug level testing on urine specimen. And for this, we can detect tenofovir, and this is in collaboration with USHore, a company in the US. And so shown here is just the validation that we have been performing on the urine drug level testing using the lateral flow device. Shown here are just some readouts that you see to indicate drug level absent or present. And so by combining the plasma drug level testing and the urine drug level testing, we can provide comprehensive monitoring of first-line ART, which is your TLD, your TFV plus LFV plus dolutegravir. And this is a really wonderful proxy for suppression. If you can detect drugs in first-line ART, then it indicates that the individual is suppressed. And this is way more cost-effective. And you can do it more regularly because all you need is a urine sample. And so in terms of improving the current South Africa strategy, what we want to do is we have patients when they start ART, they continue viral load monitoring as per South Africa guidelines, but then we add this strategy where we do routine monitoring. And by that, I mean the simple qualitative drug level test. And this will provide information as to what the next reflex action would be. And so with that, I would just like to acknowledge the huge collective effort for ITREMA, especially Dr. Lucas Hermans and Doctors Monique and Anne-Marie, as well as all our collaborators in the Netherlands and our lab director, Dr. Templeman, as well as all the wonderful staff on the ground conducting the studies, recruiting participants, following up. They have really been vital to this entire effort. And finally, the lab staff, and I'd like to thank you for your attention, and I would be happy to take any questions. Thank you.
I'd like to thank our speaker for their presentation and now hand over the session to my co-chair, Dr. Wen Sing, for questions. Thank you.